Welcome everyone. My name's Professor Chris Bain, Professor of Digital Health at Monash University and lead for our Alliance for Digital Health at Monash. It's great to have everyone along to our latest Atom Deep Dive, where we drill down on a particular topic of interest in relation to digital health. And today's session is titled Equity by Name and Nature and the Role of Digital Health. And we've chosen this session title and content because we have a range of people across our Atom Alliance and across the Monash footprint who are particularly interested in this intersection issue between digital health and equity and accessibility and how we find balances in those areas. I know we've got people online from a few countries, and that's always wonderful to see. I'm actually not in Australia at the minute, which will become a little clearer at the minute, but I just want to acknowledge the Wurundjeri people of the Kulin Nation as the traditional owners of the lands on which many of our participants are sitting in the east of Melbourne, and I pay my respects to the elders past, present and emerging. I am actually in Mumbai at the minute, and I'm hoping our connection remains strong as we go through the session today. And I'd like to acknowledge the Adivasi people who are considered the Indigenous peoples of India, and pay my respects to them whilst being in their country at the minute. Why I'm in the country, you shall see in a second as I just do a bit of an introduction for you. So again, for those of you who are new to these sessions and to what Monash is doing, we are a global university. We have obviously a number of campuses in Melbourne, the head campus being at Clayton, but we also have campuses in Malaysia, in Indonesia. We have a facility in Prato in Italy. We have a good collaboration with Warwick University in the UK. And in particular with the Faculty of Information Technology in mind, we have links with Harbin University, with Southeast University in China, both of those in China, and with the Indian Institute of Technology in Bombay, or IIT in Mumbai, as we call it these days, including the Koita Centre for Digital Health. And it's with these last partners in mind that I'm on my work trip this week. A little bit more about our alliance. So as we've said, Monash is an enormous institution. The alliance is trying to bring together numerous parties, both within the university environment and with our partners. And it's an alliance of groups through which individuals join up. We now have something like 450 people across the alliance. And one of the functions of these deep dive sessions is to give them a vehicle to talk about the work they're doing. And so today you'll hear from speakers from a variety of cultural and nationality backgrounds, but also speakers who are actually situated not just in Australia. You can see a number of our members listed there, but they're not all by far. And we have 9 focus areas when it comes to digital health. We've already had sessions about a number of these focus areas, including neurosciences, EMR optimization, digitally enabled care models. Today's session is really an expression of our interest in equity through digital health. And when we talk about equity, we're talking about or dealing with inequity on racial grounds or on cultural grounds or on geographic grounds. And how can digital health help with that situation? But also acknowledging that digital health can bring its own inequities. And so we don't want to make people's situations worse by trying to use technology that's not appropriate for the context in which they live and work. So I shall briefly go through today's speakers for you in the order in which they'll appear before handing over to them. So our first speaker is Professor Juliana Sutanto. Juliana is an IS professional and the lead for the Digital Transformation Group in the Department of Human-Centered Computing in our Faculty of IT at Monash. And the Human-Centered Computing Group has a particular affiliation with this idea of equity through digital health. Our second speaker is Professor Chris Lawrence, who is our inaugural Associate Dean Indigenous. And Chris is a person of Noongar background, for those who are interested to find out more about that, from Western Australia. He's also an active researcher himself, also in the Digital Transformation Group in the Department of Human-Centered Computing in the Faculty of IT. Dr. Jade Patel is a postdoctoral research fellow in the Department of Human-Centered Computing, and she works on participatory information governance for alternative care systems. And she is working and will be presenting today with Associate Professor Joanne Evans. Joanne is also a records expert and Director of Graduate Research in the Department of Human-Centered Computing, as well as being a long-standing educator in the Faculty of IT. And from our Malaysia campus, we have Dr. Daya Pitaloka. Daya is one of our ongoing ADAM members, has been quite active in sharing her expertise with us. And Daya sits in the Communications and Media Studies area in the School of Arts and Social Sciences at Monash University, Malaysia. And she explores issues in relation to marginalisation in contemporary healthcare. And you should see the obvious link to today's topic through Daya's interests. So I'm just going to hold this slide up for a second, just so if you wish to, if you think you might like to reach out later, if you might have questions that want following up from today's session, you're best to contact me directly and I can direct you to the appropriate person. Very simple email address, chris.a.bain@monash.edu, also quite discoverable on the web. If you want to refer to me later, rather than giving out all the email addresses for our speakers, it's easier if you reach out to me directly. So with that, we shall begin today's session, and I will stop sharing my screen and I will hand over to Professor Juliana Sutanto to do the first of our 20-minute talks. So over to you, Juliana.
Thank you, Chris. So for this, I will talk about my research on effective use of telemedicine from multiple perspectives. So sometimes people use the term telemedicine, sometimes telehealth, sometimes teleconsultations. Papers are using these terms interchangeably. So when I say telemedicine, in other papers, they can refer to it as teleconsultation, for example. First, it's important to differentiate between effective use and faithful appropriations. So faithful appropriations basically focuses on whether the system is being used in a manner consistent with the intentions of its designers. So when a system is designed, the designers often they are not in communications with the users, or they are having limited communication with the users, and it is designed with the intentions of the designers. And when the system is being used, the system's owners may assess whether the system is being used in a manner consistent with the intention of the designers or not. And that is the term which we call as faithful appropriations. Effective use is how the individual's users or organization users utilize a particular system to achieve their desired outcomes or desired goals. So when a person or an organization use a system, they have a goal in mind, and effective use is realized when they can realize their goal. So an information systems can be faithfully appropriated but not effectively used, or it can also be vice versa. From the designer perspective, information systems can be unfaithfully appropriated, but from the user's perspective, they are actually effectively using the system because the way they use the systems enable them to achieve their desired outcomes or goal. Some examples of telemedicine research from the IS perspectives. There are 3 examples here that I would like to briefly discuss before going into my own research. So for the first research, Serrano and Carhana, they examined the communication between physician and patients through task technology fit theory. And they found that user capabilities, specifically with regard to information giving and information seeking, determine the effectiveness of diagnostic tasks. Now here the focus is on the fit between the task and the technology. And it's basically the study found that it is contingent with the user capabilities. In another research, Thapa and Sein examines telemedicine projects that aim to improve healthcare in remote mountainous region in Nepal. So the users of the telemedicines are physicians. And it is basically a project that tries to connect physicians with other physicians for the equity of the healthcare in remote regions in Nepal. And they found that the physicians' perceptions and actualizations of the affordances provided by the technology are crucial for the success of the telemedicine project. So here it moves more into the user's perspective of the affordance that are provided by the technology and how they actualize the affordance to achieve the goal. Another study by Lee and colleagues examined the effective use of video conferencing technology in telemedicine camps in rural South India. And here there is an intermediary in terms of the use of this video conferencing technology, and the intermediaries are the operators. And they highlighted the importance of the operators in supporting teleconsultation sessions to compensate for user effectivity. So what, compared to these studies, what the work that I'm working on with colleagues is basically to look at effective use of telemedicine from both the doctors or physician perspective and also from the patient perspective, and there is no intermediary here. Patients basically communicate directly with physicians. So this is the research context. The research context is one-stop telemedicine applications in one of the countries in the Middle East. And basically there are three types of consultations in the app. The first is a free consultations with a GP. The second is a specialist consultations. And the third is the bundle consultations. So for the free GP consultations, they are not allowed to choose the doctor. For the specialist consultations, the patients can choose which specialists, which doctors they would like to consult to, and it is not free. For the bundle consultations are typically used by patients who would like to have, who has a mental health issues. And so they need to have a set of consultations, and they have to work together with the app team to basically arrange the appropriate bundle consultation for them with the appropriate specialist. So the data, we have both quantitative data and qualitative data. So for the quantitative data, we got the consultation reports from April 2019 until June 2020. So there are about 40,000 plus consultation records across all the three different types of consultations. And that involve more than 30,000 patients with more than 300 physicians. As you can see here, most of the consultations, so 63% of the consultations during this time, the patient was male, and for the gender distribution of the consultants, mostly are female consultants. And we have qualitative data as well. When we interview the female consultants, basically there are consultants saying that after they got married, they basically, most of them couldn't practice anymore. And the only way for them to be able to still practice their medical knowledge is through this telemedicine, as compared to the male counterparts of the consultants. And here also is the number of consultants by specialty. And you can see here that most of the consultants are basically the psychotherapy and psychiatrists. And it's also the highest number of consultations in terms of the specialty consultations. And the second highest number of consultations were with internal medicine. Another thing that I would like to highlight here is also, as I mentioned before, the highest number of consultations are with psychiatry and psychotherapists. And when we interview the patients, some of the patients who use the telemedicine for mental health did mentions about the shame issues of going to the clinic for mental health care. And so for them, these telemedicines gave them an opportunity to consult with psychiatrists or psychotherapists in the privacy mode. Some of the findings from quantitative data. So when we look at effective use, we want to understand how to measure effective use. So we did a couple of interviews just to understand what is the proxy of effective use from the data, from the quantitative data. And we found out that the proxy of effective use agreed by both the patients and the doctors are basically the rating of the consultation. So that indicates the satisfaction level with the consultation. And that also indicates that both the patients and the physicians, they are effectively using these applications. Now, when we split the analysis of the consultation ratings for the three different types of consultations, and when we combine them together to see what are the findings, we found that for the free GP consultations compared with the other two types of consultations, the GP experienced relatively low consultation ratings, and it became worse during COVID. For the specialized consultations, actually the rating became better during COVID and when it was a follow-up consultation. And for the bundle consultation, they have relatively high consultation ratings. And we want to find out more about this by interviewing patients and physicians. So we interviewed 15 patients were interviewed, and we discover different effective use dimensions for different type of consultations. For all three consultations, it matters the selections, the accurate selections of the consultation type matters. That's because some patients who have a very specific health matters, basically, if they choose to consult with the GP, then they may get a referral, and they do not want to have a referral. And if that happens, then they may give low ratings to the consultations with the GP. So an accurate selection of the appropriate consultation type is one dimension of effective use of how they can achieve their goals using these telemedicine applications. And for the consultation with GP, the patients that we interview highlighted that another effective use dimension is to enforce their goal. So the goal of the patients who would like to consult with the GP is basically immediate solutions for themselves or for their family member. And they will have to enforce the goal in the way that so that the GP, for example, did not refer them to a specialist, that they get the answers immediately. For the consultation with the specialist, during the consultation, after the consultation, they continuously assess the consultant's capability so they can see the ratings and the reviews of other patients of this specialist. And during the consultation itself, they can tailor the communication modes, and this is a dimension of effective use. So for some patients, let's say for female patients, they are not comfortable to turn on the video. So they prefer audio, or some of them only prefer the chat functions. And the ability of them to tailor the communication modes when they are having consultation contributes to the effective use of these telemedicines to achieve their goal of consultation with the specialist. For the bundle consultations, an effective use dimension is to tailor the communication mode on a weekly session. So for bundle consultation, they have weekly sessions, predetermined weekly sessions, and also during the week between the 2 weekly sessions, they can still contact the consultant during the week in between 2 weekly sessions, and they can achieve their goal if they know how to tailor the communication modes on a weekly session and during the week between the 2 weekly sessions. Now, from the physician's perspective, for the GPs, they were in so much pressures because during the COVID time, they basically received 10 consultation requests at one time. And they have to, each of them will have their own personal strategy on managing the scarce time before and during consultations. So what it means is that between these 10 requests for consultation that arrive at them at the same time, they will have to know how to prioritize which one they should talk to first. And often the patients do not fill in the form or fill in the form with very little information. So what they do is basically they make use of the chat functions before they, let's say, start the consultations. They already like pre-start the consultation by chat with the patients to ask exactly what the problem is, and then they do their own prioritizations. And they also appreciate the functions in the telemedicine that allow them, not only patients, the GP, the physician can also tailor communication modes, and they can tailor consultation duration. So for the GP, they only have 5 minutes, but they can extend the durations when needed, and most of them extend the durations. For the specialist consultations, effective use dimension is starting from their self-marketing, because patients choose the specialist. So they use the app to market themselves, and also for the using the patient's review to increase their visibility and their prominence in their particular specialty. And they will have to align their working time to the patient preference. So the patients prefer a specialist who is always in the green status. Green means that the specialist will respond within 6 hours time. And specialists, a lot of them have the monetary goals. And in order to be selected by the patients, they have to align their working time to the patient preference, which is in the green status, instead of yellow or red. And the application itself do not have all the features that they need. So they have to bricolage all the available features. For example, the form that I mentioned before, some patients really do not fill in the form. So they will have to find out with the available features how to pre-assess the patients before accept the request for consultations. And then they also like this affordance to tailor the communication mode. Consultation duration for specialists is 15 minutes, which they can extend, and also tailoring for the medical service that they provide. So in the past, there is no prescription features, and patients tend to give low rating to specialist consultations when they do not receive medicine prescriptions. And currently, there's already these prescription features that allow them to provide what they call a full medical service. I think this is culturally specific. And for bundle consultations, the consultants' effective use dimension consists of tailoring communication and consultation durations, and also the bundle sessions. Okay, so this is the divergence in patients and physicians' perspective. There is not much divergence in terms of bundle consultation. The patients and physician perspective about effective use is similar. And that's why from the quantitative data, bundle consultation enjoy the highest consultation rating compared with the other type of consultations. Whereas for GP consultation, there is a divergence here. Like I said before, patients, when they ask for GP consultation, they want immediate solutions. And for the physicians' perspective, most of the patients do not fill out the registration forms for GP to assess their cases before responding to the consultation request. And they will have to do like the pre-assessment with the chat function. And during the COVID-19, GPs received more than 10 consultations simultaneously. So as a result, some patients received no response, which affected the reputation goal of the GP. And some other patients received delayed response, which also affected the GP's reputation goal. All of the GPs, they also provide specialized consultation. So when patients write bad review about this GP, because of this, that will affect also their chance of being selected by other patients for the specialist consultations. And because it is free, a lot of patients basically use GP consultations and force their goal to get immediate solutions, although they actually need to see a specialist. And some GPs, they just go through with it and then provide this immediate solution. Some other GPs, they refer these patients to the specialist, and patients tend to give a lower rating when physicians or GP refer them to the specialist. For the specialist consultations, like I said before, patients tend to select a consultant with green status. Green means it will respond in 6 hours instead of yellow, which means that it will respond within 24 hours. And for patients, despite the poor experience with some consultants, they will still use the applications because, for example, there's no specific specialist in the region, or they live in a remote area, or they are overseas and they have a depression issue. They need to talk with psychiatrists, and they do not want to talk with overseas psychiatrists. They want to talk with the psychiatrists in their home country. So despite poor experience with some consultants, they will still use the telemedicine application because they can select other consultants. And some patients require follow-up consultations within 14 days at no cost. For the physicians, most of the physicians that we interview basically have monetary goal in mind when they register as physicians for these telemedicine applications. But then some of them, their inability to align their working time to the patient's request or demand, and the excessive consultation duration, because I see before that the consultations can be extended, and some physicians told us that some consultation can last for 1 hour, but the pay is the same. So that achieve their monetary goal. But if they shorten the consultation, the patients may not be satisfied and they will have bad rating. So they don't basically achieve their monetary goal. And there is this perspective from the physicians that instead of monetary goal, some of them still stay in the application because of the non-monetary goals, such as reputations, and then they get the monetary goal from their clinic if they have the clinic. But for female physicians, many of them do not work in the clinic anymore, so monetary goal is important for them. So that's it for my presentation. These are my co-authors. Thank you.
Thank you very much, Juliana. We won't have time to explore this with Juliana right now, but we will in our panel session. Just as I asked Chris Lawrence to share his slides, I'll just remind everybody, and I'm sorry, I omitted to mention this at the start, for all our attendees, you can use the Q&A function at any stage to ask questions either of individuals who are talking or just general questions. And then we will also be able to explore those questions and other themes in the last half an hour. Thank you again, Juliana. I'll hand over now to Chris Lawrence to share his talk.
Thanks, Chris. Yeah, so I'm Professor Chris Lawrence. I'm in the Faculty of Information Technology. I'm also the Associate Dean Indigenous, driving the Indigenous leadership strategy, research, and embedding Indigenous knowledge systems in our curriculum where they belong. And so this is also part of the research and having the kind of case studies that we need to align with our relevant technology subjects and degrees. And so this is really real life stuff that we want to share with our students so that we so they're exposed to all the diverse issues around co-designing software for Indigenous communities. So this is really research that's a collaboration between the faculty, between Monash University and also with the University of Technology, Sydney, my colleague there, Associate Professor Tak Leong, and also Melbourne University and my colleague there, Dr. Greg Rodley. So I'm not sure, there we go. So I guess I'll start from the beginning. So as I said, this is an Australian Research Council Indigenous Discovery Grant that we got in 2016, and really looking at how to co-design technology for and with Indigenous communities in Australia, particularly, and looking at how technology can help close the gap in terms of improving Indigenous health outcomes. And for those of you who may not know, Indigenous Australians are more likely to die younger and have from preventable diseases, chronic diseases, particularly heart disease, diabetes, and cancerous diseases. So this work is really critical and important in understanding how digital health can help improve access to information, knowledge, I guess making all those kind of important decisions in people's lives. And we know that Indigenous people are using technology, and I'll get to that in a little bit. I wanted to kind of share where we are at in terms of the research that we did to start with. And so we kind of came up with this idea. It was really around connectivity, understanding how Indigenous people use technology, what do they want from technology. And this was at a time, obviously 7 years ago, 2016, we started writing the grant in 2015. And at that time in 2015, I don't have a slide on it, but there was a online petition to bring down a app called Survival 3 Australia, and you can Google it, which no longer is allowed to be used in Australia or accessible. Not even sure if it's available anywhere now, but it was available on Apple and Google and Amazon. And it was really effectively about how you could bludgeon to death an Aborigine you playing this horrible game. And so as offensive as it was also critical for our research because it actually, demonstrated that we were on the right path, that Indigenous people often don't feel safe in the real world, and they certainly don't feel safe in the virtual world. So this really enforced and reaffirmed that our research was critical, and we believe that was also part of the catalyst of why we got the funding for this project. So we started out going around the country. I don't have a slide where we went to, unfortunately, but we went around around Australia to different communities, and we wanted to have a diverse kind of, because Indigenous people are not homogenous, and there's all these different language groups, and there's all these different cultural practices and relationships and identities. And so we wanted to capture what did that look like from an urban Indigenous perspective to a rural, to a remote and very remote regions. And if you know Australia, then you know that that's basically Australia's landscape. We're very, very remote in terms of the further you go to those northern parts of Australia, the more remote it is. So we kind of came up with these different versions of, it was really, again, coming back to this connectivity and understanding how do Indigenous people connect. And so we had all this input from all these different groups, and we came up with this idea that it was about, because we call each other mob. That could be our clan, our tribe, our community. So my mob are Noongar people. I'm a Noongar. But inside Noongar, that's just a generic term for our Noongar nation, which is part of the southwest of WA, Western Australia. There's actually 14 different clans, and I'm a part of 2 of those, or maybe all of them really, and through marriage as well as all the other bloodlines. But so it's kind of complex, and as you can appreciate, and so we have totems and we have song lines, and we have languages, obviously, and dialects, and so all this kind of shapes us in our identity. It can tell us who we can marry, it can tell us who we can't marry, it can define our relationships with people in our communities. And this is a very strong cultural practice among all these Indigenous communities. I would say that's probably across the globe, but from an Indigenous Australian point of view, these practices are very much still practice. And this is what really was informing our platform, This is My Mob. Go to the next slide. So connecting to my mob, right, was one of those key things. And we came up with this idea, where you, and I guess it wasn't really, I'm just conscious of the time, it wasn't really meant to work out the way that this has turned out. It kind of turned out to be a mix of Facebook and LinkedIn. And that's not really what we set out to do. But every time we went away, we went to the community and got information and went back to our hotel and drew up all these kind of diagrams, me and the technology software computer guys, that we realized was really about a social connectivity platform, and that where Indigenous people wanted to feel safe and have their own platform. They didn't want to, initially we were saying, do we make this for all Australians to connect with Indigenous people? And they said no. They wanted to have their own platform so that they could share information and about their own communities and what was happening and how to bring those communities together and kind of, reconnecting and kind of having this sense of digital land rights. And that's really what this these slides are demonstrating, how we kind of drew all this together and came up with these different features and functions. And there's my community there that you can see in the red. That's part of Western Australia where I come from. And we have a mob talk, as we say, like it's a news feed where information could be shared. It was really too about making sure that all the different Indigenous content that is available on the website is actually available on one platform, and it's kind of safe platform where people can share information and talk about their communities and what's happening in their communities, and have all these different types of I guess cultural contextualizing of features. And 2 of those is we have a men's business and a women's business, what we call, and that is where men's business is really about drawing from Indigenous cultural ceremonies through initiation and traditional practices where young men are taken off to be initiated into manhood. Same for women, where there's women's business that was really also about all those being initiated into becoming a woman, and also birthing and all those women's business. And so it was really what the community said, we want men's space and we want business, men's business, but we want a women's business space as well. And it'll all make sense again when we come back, because what was really interesting from this is that the software developers couldn't understand why did some of them felt it was sexist. And it's like, well, no, it's not sexist. It's actually the way the community actually operated and has always operated for over 65,000 years. And so that's part of this authenticity and making it Indigenous in terms of using, the latest technology and systems to actually incorporate Indigenous identities and businesses and practices into a software platform. That's not an easy thing to do. And I think, our research has shown, well, you can do it. And it's not a one-way learning experience either. This was about software engineers and researchers also being able to learn new things and share new things and share their knowledge with the Indigenous community. It's about that reciprocal kind of shared benefit of information. And that was really powerful for those software developers. And if you remember, when I opened this conversation, I talked about that Survival 3 Australia app and that, about bludgeoning to death Aborigines. That was really the catalyst to say, well, yeah, that's how you shouldn't design software, right? Because it has these offensive and detrimental kind of impacts on users, and it's racist, and it shouldn't be allowed. And so we want software developers to understand that there are ways to ethically ways to create software for diverse communities and for Indigenous. And this is kind of drawing on again, this news feed and sharing this. And as you can see, it looks and even feels like, LinkedIn and Facebook. And that's okay. It turned out that this is the way it kind of evolved. And it's a research project, right? So we were learning and they were sharing knowledge and learning from us and vice versa. So we really wanted to understand, well, what does this really mean when, for software developers and in the human-centered computer interaction research world, really, sharing a new knowledge that didn't exist before. Now, I must admit, I'm showing Curtin University down there. I apologise, that was where I used to work. This is Monash. I thought I changed the logo, but that's okay. So Curtin University, which is in Western Australia, also collaborated with us. And you can browse all these different mobs, right? So if you can see, these are the communities that we went to. So we went to the Bard mob, which is up in the Kimberleys, up in the Western Australia, in the northern parts, and the Eora mob, which is Eora Nation in New South Wales, Sydney, and throughout all of New South Wales. That's the Eora Nation, and they've got all their different tribes, clans inside their nation. And then there's the Noongar Nation, my mob that I talked about, the Tiwi Islands, which is right up on the tip of, you have to get on a small seaplane. You fly into Darwin, and then from there you get on a small seaplane and you fly to the islands. So I'm just conscious of time. I'm going to move on. So then there's the Gundit Mara mob, which are down in the southwest of Victoria. So all of this I want to speed up is to show you that we actually designed this software platform for Indigenous users, right? And there again, you can visit those mobs. I'm going to fast forward to what happened in 2020 with COVID. And so COVID, obviously the whole world, right, closed and everybody was forced online, including Indigenous people and including Indigenous Australians. And who knew that Indigenous people could use technology? Well, they can and they do, and we do. And so what we were doing, obviously this impacted on a whole range of different services, including Aboriginal medical services. And so I think Juliana's slides earlier really kind of reiterated what we were doing too, to understand how can the uptake of telehealth actually work for Indigenous Aboriginal medical services, as we say here in Australia. And we know that the cost of those telehealth services were being subsidised by the Australian government at the time, but they would charge tremendous amounts of money, and these services don't actually have that kind of infrastructure, and not everybody uses that high-end level of telehealth products. No one's at home measuring their blood pressure and heart rates and doing all that stuff and sending all this, health data to their physician. They're not doing that. what they were doing is using the video and the phone call to have a consult on the phone with their doctor, and using the chats and sending images of wounds or whatever it was that they could do online. Obviously, it's not going to replace face-to-face and emergency stuff. But at the time, the light switched on for us that we could transform this platform that we'd created earlier, that I showed you, that this on my mob platform. So now we repurposed it. We went back to our software developers and said, hey, can we repurpose this software? Because we needed to, we were all kind of nervous and anxious as well, like everybody. And we wanted to come up with something really fast and quick to give to those Aboriginal medical services so that they could stay in touch and connect with their communities, their patients, their doctors can be on standby. So everybody, it was kind of that emergency response, right, that everybody was doing. So this was our way to address that emergency response by creating this, repurposing the software that we'd already created. We just put all the information from the Aboriginal Medical Service that we're working with the Southwest AMS. We put all their information into the platform, as you can see, all their programs. Their patients can actually use this as their client profile. They're all Indigenous as well, so they can use all those types of identity features that I talked about. So they can put in their land, their languages, their mob. So it still has that Indigenous kind of, sense of authenticity in it. But it's a medical telehealth app. So this is what we created. And now obviously you can see it's took on a whole new life of its own. So this is where we feel that, it became its own platform. It looks completely different. It actually operates completely different. And so this is kind of the early features where it's actually ready to be deployed. It was finished this year because of the delays and of COVID, and obviously we got the funding extended. So used all our research funding to actually build this in the end. And we got input from the Aboriginal Medical Service. So they gave us all this kind of medical info that they wanted. And so now it does have a fee, where they can make bookings, they can have a telehealth consult. The doctors, all the users are the Indigenous patients of that service, the medical staff and the Aboriginal health workers, plus the staff of the admin staff of that service. The next step is, we're about to deploy the app, which is now called SWAN's Mob app. We're about to employ, and if anybody out there knows someone who's interested in a role, an Indigenous Research Fellow, to conduct evaluation and monitoring effective pilot study, publish our results, approach other Aboriginal medical services to explore further rollouts with their version of the app. So we'll just reskin it and repurpose it, maybe update it with those things that might be different for those regions. Secure more research funding and collaboration. So if anybody's interested, please reach out through Chris Bain, and explore global Indigenous opportunities. As Chris Bain mentioned, Professor Chris Bain mentioned, Indigenous people are there in Adivasi people in India, and we want to work with them. We want to say, well, here, maybe this app might help them. They can repurpose it and they can lead it and deploy it in their communities. So I'm going to leave it there. Say thank you. I appreciate it very much.
Thank you, Chris. Thank you. Just to reiterate what Chris Lawrence has just said, I did a little bit of research after speaking with him before my trip to India, and the Adivasi people in India represent, I think it was about 8% of the population, but 8% of 1.4 billion is an awful lot of people.
150 million, I think.
And I know Chris has also had conversations on previous trips to India where that's an important issue for the Indian government. And it's another way of saying Chris Lawrence has a lot of interest in indigeneity across different settings, not just in the Australian setting. Please do ask your questions in the Q&A. Plenty of opportunity. You've got a wonderful group of people with amazing experience you can draw on here. So please don't be afraid to ask questions. There's nothing like a wrong question. Any question is perfectly valid and interesting and worthy of discussion. I'm now going to hand over to our next speakers together. So Dr. Jade Purcell and Associate Professor Joanne Evans to talk us through their slides. Thank you.
Thank you very much, Chris. So good afternoon, everyone. And it's a great pleasure to be here presenting in what is a new disciplinary area for me. I acknowledge the traditional owners of the land that I'm presenting from, the Wurundjeri people, and I pay my respects to elders past and present. So I'm a social worker with a social sciences background who's been conducting research and consultations with some of the most disengaged young people transitioning from care for about 10 years now. And here in the Faculty of Information Technology, I'm working with Joanne Evans and colleagues to model real-time rights-based record-keeping governance for out-of-home care. So one issue that's frequently raised by care leavers is their access to records made and kept about them during their time in care. And one of the reasons for this concern is health data. So Joanne has been involved in care record keeping research for around a decade or so also, and there are several other issues in record keeping practice and governance apart from health records that affect children and young people and impact the adults that they become for the rest of their lives. And Joanne will explain some of this shortly. However, first I'll just present a little bit of context for you. So we can go to the next slide. So we're talking about care records as those pertaining to people who've lived in government out-of-home care, or as it's increasingly known locally and internationally, alternative care. This happens when a court orders that you be removed from your family for maltreatment usually, or if your parents cannot care for you, perhaps because of domestic violence, mental illness, imprisonment. So while children may be removed from unsafe situations, significant trauma has often been experienced. Most Australians have no idea that young people were previously exited from care on or before their 18th birthdays, with little to no ongoing support. The health system has often been the only remaining system available for help in a crisis, and many care leavers have extensive contact with the health system. Also, for politics at large, out-of-home care and transitions from care have often been regarded as niche policy issues. So if we just go to the next slide, Joanna. So the recent Australian child maltreatment study has just made it quite clear that child maltreatment is not a niche policy issue. It's not confined to people experiencing Child Protection Services involvement. Australia has a massive problem with child maltreatment. This study's results suggest that over 5 million Australian adults have been sexually abused as children. And the Australian Child Maltreatment Study has also contributed invaluable evidence concerning the health impacts of maltreatment. So we can go to the next slide. And what these statistics show and tell us is that the National Association for the Prevention of Child Abuse and Neglect, NAPCAN, what their motto of protecting children is everyone's business. It's quite clear that it extends well beyond child protection. And there's a strengthened mandate here for transdisciplinary work and extra investment in optimising electronic medical records, but other digital care records as well, for better oversight of children's health and safety. What we can't afford to have happen is for electronic medical records to replicate the surveillance bias and rights infringing practices of current paper-based paradigms. Next slide, please, Joanne. So what we can see is that the health system is working with many patients with trauma histories, Many of these patients have been victims of abuse in institutional settings or experienced further trauma through child protection and other authorities' interventions. Care provided for victims of abuse must be sensitive to their often very justified fears of and anger towards authority. We also can't know who's been a victim, as the numbers are high and disclosure rates may not be. Trauma-informed care doesn't hurt people who haven't experienced trauma, and treating people with care and respect typically de-escalates situations and makes people's jobs easier. We've got many overlapping interests between child protection, out-of-home care and health systems, but we have little in the way of overlapping work, projects and collaboration. So, how do we make provision for the physical, intellectual, emotional and spiritual development of a child in these systems? Well, we don't really. What feels like hundreds of public inquiries will tell you that. I wonder what the next really expensive Royal Commission will have to say about a whole range of other things that we already know. Being in out-of-home care for any period of time means having records about your childhood distributed over a whole host of systems. You and your family's behaviour is subject to intense scrutiny and documentation, with many, many people and different kinds of professionals involved. Health and medical records are a major part of this vast array of record keeping. Digital records and the sharing of them have big, real and lifelong implications for care experienced people. As a short aside, my PhD study concerned care experienced early parenting, and care records create real risks of surveillance bias and parent avoidance of health services during pregnancy and children's early years as one example of the issues that are at play here. So this is where the research that Joanne and colleagues have done comes in, and I'll hand over to Joanne to tell you about that.
Thanks very much, Jade, for setting the scene there. And I'm delighted to come from you from my home on Bunurong country. So as you can see, Rights and Records by Design was an Australian Research Council discovery project to look into the infrastructure needed to transform care records and record keeping so that they can better recognise, respect and enact multiple rights in records. And I come at this issue as an archives and record keeping researcher, educator and professional, listening to the decades of activism and advocacy from those who have grown up in various incarnations of Australian child welfare and protection systems of the lifelong importance of childhood records to health and wellbeing. And a sketch note from our May 2017 summit shows the challenge is to imagine, design, develop and implement a human rather than a legal framework for care records and record keeping. That means that rather than being perceived as mere instruments of bureaucracy, record keeping processes and systems are conceived as playing a positive role in nurturing and developing a child's sense of self, feeling connected to family, carers and community, having safety, health and wellbeing needs met, ensuring efficient and accountable decision-making and action by all the different organisations in the care system, and decreasing rather than increasing administrative burdens for all those in the sector that want to act as a good parent would for the children and young people in their care. So first up, to highlight the data of lifelong rights in childhood record keeping for out-of-home care, which was led by my colleague, Professor Sue McCamish. Drawing on the testimonial warrants of lived and living experience and record keeping implications in a range of human rights instruments, the Charter has identified a set of record keeping rights to address the lifelong identity, memory and accountability needs of those with care experiences. Sorry, it's probably a bit small on the Zoom, but on the right there, the record keeping rights are participatory record keeping, the right to participate through record keeping in the decision making that impacts on one's life in care, and rights to privacy of those records and in the information and agency in their access and disclosure. So the second outcome from our project is our emceed prototype for representing and enacting record-keeping rights in digital systems design. And here I had the great pleasure of working with a wonderful team of young care leaver advocates, Rhiannon, Matt, Liz, Ella and Aidan, and my Faculty of Information Technology colleagues, Greg and Han, to create a research prototype of a personal record-keeping system for a care experienced child, young person or adult to have access control over their distributed care records network. What does that mean? Well, we've conceptualised emceed as a care experienced person's own record-keeping system to interact with all the other systems in this network on equitable terms. We want to break the shackles of being forever the client, subject, or the case of an organisational record-keeping system to have a way of appropriately participating in their own care record-keeping, to know that the system is keeping stuff safe and secure and that it can be accessed without unnecessary bureaucratic hurdles. So the quickest of overviews of emceed's features on the left are those for creating and managing a person's own personal information and records, and on the right, those for finding and accessing the care records that others create about you. Bringing the functionality for managing personal information and records and other care records together in the one system is really important. Firstly, it overcomes the difficulties in negotiating a bewildering array of organisational systems and processes for getting access to records. And record-keeping rights to proactive access and disclosure of records are embedded for all rather than having to be individually fought for. Secondly, it enables some control and oversight of how personal information and records are shared and used by others, moving from being that passive subject of records to an active participant in their creation, management and use. It's actually that end that I'm particularly interested in discussing with the ADAM community, particularly in light of the May deep dive into electronic health and medical records. emceed is more than just an app, but it's the beginnings of a blueprint for a network participatory record-keeping infrastructure with massive technical policy and governance implications for the care sector. It's a design provocation, tools of and for making that human framework for records and record-keeping a reality. It establishes the need to invest in the integration mechanisms, the technical interoperability, along with the co-production, sharing policy practices and cultures that would be needed for implementation. So I'll now hand back to Jade to talk about the next stage of our research.
Thank you, Joanne. Just clipping some notes back there. So it's my job in all of this to work with care experienced young adults with extensive policy advising and advocacy experience in an emerging co-researcher participatory paradigm to imagine and propose solutions. Our work and findings will then be presented to care system, including health system authorities, for some real-world testing to apply transdisciplinary knowledge and experience to the challenge of creating participatory information governance. And if we had more time today, I'd be really keen to talk to this group about administrative overburdens, misplaced metrics and goal displacement across our health and social systems, systems thinking and governance for compliance and accountability, and functional fixedness in our policymaking processes. And so go to the next slide, Joanne. And so across disciplines, we have many shared problems, which we use different terminology for to explain different but not necessarily opposing agendas. The May ADAM deep dive presentation on optimising electronic medical records addressed another problem related to participatory record-keeping governance, which is data collection purposes and functions across our health and social services. For the health system to optimise the use of patient data, there are many barriers and enablers, very much identical to what I've just referred to on the last slide. To overcome administrative overburdens, goal displacement in metrics design, systems blind reform, and functional fixedness, we need deeper collaboration, interoperability in systems design, co-integrated records, and the informed and dynamic consent of the people whose information we seek to use and share. We need to be working with people with different expertise, but across problems that affect all of our disciplines. We need to ensure children and young people in care are involved in creating records about their experiences in care, that care systems tell children and young people why they're in care, that health systems can include family history and health assessments and maintain the privacy and confidentiality of very sensitive records. IT systems can facilitate this when they understand more about the needs and experiences of people maltreated as children, and legal services and systems need to enshrine children and young people's rights into regulatory systems and legislation that protects those rights without impinging on them. And all of this needs to be developed with care experienced people represented and resourced to participate in meaningful ways on individual practice, group and collective levels. Next slide, please, Joanna. So this is an excerpt from the National Model for Clinical Governance. And in looking at that, I've seen how it sort of divides things into individual, group and collective levels of patient participation. And so that's very much transposable to other examples of participation, such as in out-of-home care. We're running a little bit low on time, so we'll just move to the next slide. So in participatory information governance of health systems and care systems, care experienced people need to be represented in decision making about record keeping and data collection processes to ensure that their rights are upheld. This also has the benefit of improving our data systems, as many care experienced people distrust authorities and will not necessarily voluntarily or otherwise comply with demands or requests made by authorities. Much of our research doesn't include representative samples of care experienced people, as many studies rely on voluntary participation by people reachable by mobile phone, landline, or stable address. And the rights to be listened to, taken seriously, and have views taken into account in decision making are enshrined in the United Nations Convention on the Rights of the Child, Article 12. To make these an everyday reality, our project will work with care experienced co-researchers, statutory authorities, and healthcare systems actors. So, I'm not sure how familiar people here would be with participation theory, or with, you might be familiar with the IAP2 spectrum of public participation. But so many participation theories have articulated the ways that children and young people's rights can be negated, tokenised, or realised. And you might be familiar with those. What I've learned in putting this presentation together and thinking about transdisciplinary work to develop participatory digital record keeping systems is that transdisciplinary collaboration and action can sit on very similar continuums or spectrums of participation. It can be tokenistic or solely symbolic for tick boxing and backpatting purposes, or organisations, disciplines, parliaments and governments can work together on shared goals. Alternatively, all of these actors can incorporate co-design and co-production functions into their governance structures to ensure that expertise from the coalface of our services is fed into our work to build, maintain, innovate and reform our services to maximise efficacy and efficiency while protecting the health and safety of vulnerable and marginalised Australians. Ensuring that we do not continue to exclude such groups from our policymaking processes is not just the right thing to do, it also builds foundations from which vulnerable and marginalised groups can access opportunities that the rest of us take for granted. And the references slide. That's it for us.
Thank you, Joanne, and thank you, Jade. Lots of interesting and curly topics in that for sure. I'm hoping some questions will come through from the audience. I have a couple for later if we don't have any questions from the audience. Thank you both very much. And I'm really pleased at the different dimensions that are coming out from our different speakers today on this broad topic of equity in digital health. I'll now hand over to our final speaker, Dr. Daya Pitaloka from our Monash Uni Malaysia campus to take us through her talk. Over to you, Daya.
Thank you so much, Chris, for this opportunity, and thank you so much. I learned a lot from the other participants, the other presenters about how we can understand these digital health, digital technology, and equity issues from interdisciplinary perspective. Okay, so this is an ongoing work, and in which we are currently stepping into the second stage of the study. And getting ready to explore the use of digital technology, disability movement, and social inclusions in Indonesia and Vietnam. So today I'm going to introduce you to some part of the data that the findings that we have collected, and it's about contact tracing app and users with disability in the Global South. So. To give you a background, there is no doubt that while the COVID-19 virus does not discriminate between non-disabled and disabled individuals, much pandemic-related information and technological solutions limitedly meet the need of users with disabilities. No doubt that contact tracing apps magnified the potential usefulness of mobile media and communications technologies for responding to disruptive events such as the COVID-19 pandemic. So CTAs has been designed to accrue people's mobility data, which authorities later promoted as necessary for flattening the infection curve, zoning high-risk areas, and forcing people to stay in shelter or in their home. So in several European countries, for example, the belief that CTAs will help monitor the virus spread has become a prominent reason for people to use them. So the efficacy and ethical debate on CTA have become the focus of recent studies in the global north. Reasons for using contact tracing apps among users with disability, on the other hand, especially in the global south, seems to be understudied. So we are focusing on exploring these particular nuances in this study, and I'm going to share with you the results and findings that we get. So when we discuss about issues and challenges in regards to technology use, especially among users with disabilities, so the literature review took us to identify three main challenges in terms of technology use and users with disability. The first one is the ethical element. This is quite obvious. So transparent rules on data access, use, storage, and retention, including political economic ramifications of access to such data by those in power. So CTA potentially unleash threats from the accumulations of personal and mobility data by the powerful without transparent rules on data access, storage, and retention. The second aspect that is quite important in terms of technology use and users with disability within the context of pandemic and emergency situation is that not everyone has the capability to reallocate their depleting incomes due to the pandemic to afford the internet. So this widened the digital divides. So some of the CTS features, such as Indonesian Peduli Lindungi or Care and Protect, are inaccessible to screen reader as well, and talkback users are incompatible with their model of mobile phone. The third aspect is about reasons for using CTAs and related ethical debates that have mainly revolved around non-disabled users, even though users with disability are greatly affected by the pandemic, given their pre-existing vulnerabilities, such as systemic discriminations and limited access to political and economic opportunities. However, these literatures, these data, social technical understanding of CTA has mainly stemmed from the context of the global north and high income country. Now, given the complexity of the pandemic situations in the two countries, Indonesia and Vietnam, as well as the socio-political dynamics that are affecting them, it is not our intention as a team to compare the usefulness of CTAs, but rather we would like to show the reasons for contact tracing app use among users with disability as a single case. So our study is guided by these two following research objectives. First, to discover nuances surrounding the use of contact tracing apps among users with disabilities living in Indonesia and Vietnam, and to understand how do such reasons for the use of CTAs reflect the values of users with disability as citizens. So the interviews comprise a set of 53 semi-structured interviews carried out in Indonesia and Vietnam. We conducted the interviews to 28 Vietnamese and 25 Indonesian people with disabilities in the first quarter of 2021. So out of a total of 53 interviewees, 27 were women, and majority of these participants identified themselves as people with motor, vision, and hearing disability. So all interviews, transcripts from both countries were treated as a single data set, which we then iteratively analyzed together. And our intention was to seek reasons, as I mentioned, for using CTAs among users with disability. So we're not comparing behaviors. So to provide you with some context about Indonesia and Vietnam, I'm very fortunate and very humbled to be able to work with the community of disabilities in the two countries. Spoke to the leaders, worked with the team of researchers, both actively engaged with disability issues, and also colleagues from university in Vietnam, from RMIT Vietnam. So Vietnam and Indonesia have common characteristics, but are politically different. They both are members of the Associations of Southeast Asian Nations, or ASEAN, with decades of bilateral relationships. One unique thing that mark the similarities between the two countries is that nationalism has marked various health communication programs in the two countries prior to and during the pandemic. In Indonesia, for example, during President Suharto's administration, the nation-building spirit was integrated in family planning campaign. And during the pandemic, civic nationalism has characterized public solidarity and the government approach to security vaccine. Similarity in Vietnam, nationalism, which was rooted in the country's war experience, had buttressed the health communication strategies the government deploys to defeat the virus. So in these two countries, CTA were widely implemented as part of the pandemic responses. So the Indonesian government strongly encouraged citizens to use Peduli Lindungi app. It's the one on the right of your screen. Only a small percentage of the society initially use it at the beginning, but in the middle of the pandemic, usage greatly increased once mandatory declarations of vaccination status took effect. The Vietnamese government initially mandated its citizens to use two different contact tracing apps, Blue Zone and NCOVI. This too was a private and state developed, so a combination of private and state developed CTA, while NCOVI was actually a fully developed by the state. But later on, the Vietnamese government changed the policy and introduced one single contact tracing app called PC COVID. And this app merged various health surveillance apps for a simpler contact tracing system. And of course, if with this contact tracing app, scanning the app's QR codes become a new rituals in the everyday life of the people, as failing to declare their health status would lead to rejections to enter many public places. So when we discuss about contact tracing app and disability issues, and this is actually the aspects that I'd like to highlight in these presentations. So the deployment of CTA has signaled a big win for surveillance and datafications through mobile devices. State and privately sponsored CTA developers for Indonesia. This is a state and private companies working together to develop the app. So for Vietnam, they basically created in the first part of the pandemic a combined private state collaborations CTA, but at the end, government take in charge and come up with one single app to replace the previous one, and this is a state-owned technology. So the state and privately sponsored CTA developers have taken advantage of the pandemic situations for accumulating users' data. So although health surveillance still play an important role in tackling public health problems, the questions of who will have access to the data and what for are unclear. So one issues that so in the past decades, one issues that becomes the major concern in our discussion as a disability scholars and media communication scholars is how the intersections between technologies and disabilities has generally revolved around improving access. So CTAs have exemplified a rapid global adoptions of mobile app in a volatile time. So the emergence as a part of international pandemic response has shown that new ways of aggregating and using mobility data for keeping the nations healthy. But one aspect that our participants discussed during the interviews is how the deployment of contact tracing apps is basically do not meet the needs of users with disability. And they mentioned specifically about the role of users with disabilities in any emergency communication. So for example, using the CTA, you will be able to identify which place you visit and which place you must avoid. So here in this context, participants express their concerns about how they are unable to benefit from knowing what places to avoid or indicate where they have been. So this is an issue of building tracing data sets where the voices of users with disabilities have almost muted. The second aspects that participants identify in relations to how and why the deployment of CTA do not really meet the users of disabilities needs is because they need to be able to identify obstacles that, in particular, visually impaired people encounter in everyday life and travel. So most of our participants, they hardly travel, to be honest, even though they downloaded the CTA. I mean, because of their conditions, they mentioned that we basically confined in our house, in the room, with their condition. This has been part of their everyday life. But even with the CTA, none of them basically take an advantage of being able to use CTA to navigate their everyday life and travel. The second aspect in relations to CTA and disability issue is how CTA and the design of CTA contribute to digital divide. So first, they identify the technological affordability and accessibility, primarily when downloading CTAs. So most of our participants use a very basic mobile phone, and what happened is batteries drain out when they try to download the apps because they have to utilize and activate Bluetooth. The other thing, of course, the internet connections, the connectivity becomes the issues. The second thing that they identify is the low accessibility of CTA's features and design to blind and visually impaired users. I would like to highlight the accessibility of privacy and terms, because later on in my last slide, I'd like to introduce you to different aspects of or reasons of why people with disabilities in these two countries, regardless these two aspects, downloaded and still use CTA in the everyday life. So no access to privacy and terms creates a lower literacy among users with disabilities. So it's very interesting to then further in our conversations with participants that none of participants in these two countries, none of them shows resistance to use CTA. The participant shows no reluctance at all in using and even sharing their personal data, downloading the app, use the registration form and upload their personal data. So they do not have or receive or able to, so they do not have or receive or able to access data privacy information page regarding personal data use. I mean, when we talk to a non-disabled community, they do care less actually with this particular information. But during the crisis, this piece of information, data privacy information regarding personal data use is a very important condition and very important aspects that needs to be highlighted and carefully communicated to users. So in this case, none of them are exposed to or able to find or receive, if I can put it that way, data privacy information. So the only reason that got them to believe in this CTA, use CTA, is their faith in the state. So this is the first reason behind the use of CTA among users with disability in these two countries. So one of the main motivation is so that they can partake in the national effort to tackle the pandemic. So it's more like a moral obligation. And secondly, I don't really like the statement, but participants said that, well, if there's nothing you can do because of your disability, then at least you can help the country by supporting the decision. So regardless the law awareness of privacy and data protection rights, the state are more trustworthy. They trust the state more than other entities such as private citizens and companies in the context of responsible use of personal data. The second reason behind the use of CTA is this cultural values. So demonstrating good citizenship and beneficence, and these are rooted in the cultural values of the people. So for Indonesia, it's part of their sense of working together or gotong royong. And this is basically a reflections of individual agency and also a reflections of their being good citizens and how they, their intention to assist the state in saving the country from COVID-19. So collective objectives represent this cultural spirit embedded in the everyday life of the users. So as citizens, supporting the state was essential, particularly when there was a belief that they had nothing else to offer. So the spirit to help the government manifested in participants' willingness to use CTAs without doubt. And this is why I believe further studies need to conduct and bring together policymakers, tech designers, and users to carefully address this issue and to make sure that information, important information such as a policy, data privacy information can be accessed and has to be able to be accessed by users with disabilities. So just to close up, just to conclude and to close my presentation, in this context, we argue that CTA becomes a connector between individual, collective, and state efforts to curb the pandemic. Nothing more, nothing less. But there you see there is a lack of conversations that happens that we hopefully can be able to address in our future research. Thank you.
Thank you very much, Dia. Very much appreciated. Again, lots of interesting things to unpack there. And just a reminder for all our attendees, please do take the opportunity to ask some questions of our participants, either general questions or specific related to their talks in the Q&A window, which you can open from the Q&A tab down the bottom. Just while we're waiting for those, Juliana, can I ask you a question? Coming back to one of your early slides, you made a distinction between faithful appropriation and effective use. Can you just expand on why that's so important and maybe an example of where that's gone wrong? Are you able to talk to that?
Yeah. So faithful appropriation is basically whether the users use a particular features of the system or the application as how the features are intended to be used by the designers. Effective use is basically how the users use a particular features of the system or the systems to achieve their goals. And because a lot of the time the systems designed by the designers are not in collaborations with the users may unfaithfully appropriate the systems, but then the users actually categorize that as effective use because they managed to achieve their goals. So one example, for example, from the telemedicine that I mentioned, one feature is that it is not mandatory for the patients to fill in the patient's form when they request for consultation. So some patients skip the form, some patients just fill in very little information, and this is very difficult for the consultants to assess the patient, especially for GPs. During COVID, they receive 10 requests at the same time, and they have to prioritize, and it's difficult. So they basically unfaithfully appropriate text chatting function of the app to have a chat with the patients pre-consultations to basically ask the patient to specify what the problem is. So for them, it is effective use. They get the goal, the sub-goal, which is to better understand the patient's condition before the consultation, but it is an unfaithful appropriations of the feature that the designer intended it to be used. So yeah, that's the difference.
Thank you. Actually, that's, I suppose, another way of putting that, isn't it, is the gap between the intended appropriation and the actual and effective use is a marker of system success. If those two things are well aligned, then that's good. And where they're not, that says the system's overall not been as successful as it could. And arguably in really tricky user groups like disabled people or less educated people, that problem might come to the fore even more. So that's a good way to put it. Interesting. Thank you. Thank you, Juliana. Chris, again, just to remind everyone, please, please, Joanne, go ahead.
I just want to say, who is it a problem for? If we're talking about equity, it's like, is it actually the designers that are, if someone's actually showing this is what we need to do this work, and they're using a workaround, then that would actually be where the designers need their system to go. It's like, rather than pulling people away from that or really investigating that, I guess. I know in the social work context, because people are dealing with such sort of resource strapped area, that bricolage and making do and working around is actually the way that things get done. It's like, then there's a lot to learn about that, rather than trying to impose systems because of that complexity that they're dealing with.
Yeah, and look, when any of us who work with technology a long time have seen examples where it's built for one purpose, it gets used for another purpose, and as long as that's good for people at the end of the day, it doesn't matter that much. But it's still interesting. Either way, it's a marker of quality, or it's a marker to pivot and shift and improve the functionality. It's a good way you've expressed that too, Joanne. Just a reminder for our audience, please, very happy to hear from you. Lots of things you can be asking our speakers, so feel free. Chris, just conscious that not everyone's from Australia, not everybody will have a great Indigenous knowledge. You briefly put up the little map of Indigenous groups around Australia. How many roughly ballpark Indigenous groups and language groups are there? And is there a one-to-one correlation, or does a given group maybe have 3 or 4 languages?
Yeah, Indigenous people in Australia make about 3% of the population. It's about 20 million people in Australia, so 3% of that. There's about 350 Indigenous language dialects across the country. So that gives you a broad sense of how many Indigenous communities there are. There's about 300 Aboriginal medical services, including clinical satellites across the country, both urban, rural, and very remote regions. So I guess that gives you a broad sense of and how big the continent is. And obviously we're very remote in terms of the location of Australia. So yeah, it's huge. But again, we're a small population in terms of the bigger, but we have the most, like I would say, probably, I don't know the statistics in other parts of the world with Indigenous communities, but obviously you look at places like in India, right? It's Indigenous populations are the poorest, are the sickest, are the most incarcerated, and most marginalised communities. So, if we can't, there's all this effort going to try and fix the problem. Indigenous people are not the problem. We've never been the problem because we didn't go anywhere to create problems. The problems came to us. And so we need to be able to be the leaders in how we fix the problems that we have to deal with, which often obviously coming from colonisation. And no, we're not the lucky country to have colonisation, which one of the ex-prime ministers made public today, which is such a poor example of leadership. But I think, we understand we have to share our countries and cultures with other cultures and other people here. But at the end of the day, that, we need to be respectful. And we do this obviously with other Indigenous communities. And I would say that, there's Indigenous communities throughout Southeast Asia. We know that, even we're in Indonesia and Malaysia, where our campuses are, and we need to do more work in collaborating with them. And I guess, not to say that, Australia is obviously leading in lots of ways, but again, we still got the highest rates of health outcomes and early death rates among Indigenous people. So we've still got a long way to go.
Thank you, Chris. Thank you. Please, Dia.
I think Dia was going to say something.
So no, I'm very interested. Thank you so much. So Chris Lawrence, Prof. Chris Lawrence, it's very interesting because I think I personally see that it's not that Indigenous community, there never be a problem, but I think it's because we never actually include them in the equation. So we received a question from one of the Indigenous, and sadly in Indonesia, we don't really use the word Indigenous. I know that this word come from in English, we do have the word Indigenous. We don't have any word to translate that in Indonesia. So the best word we can use is marginalized. And this is actually hurt a lot. I mean, hurt me a lot in a way that when you categorize a particular community as marginalized, it means there is no opportunity. So they ask a question. So in terms of design, we happen to have a tour to a secluded Indigenous community village. And they ask questions that, of course, because of my background, I wouldn't have any ability to respond. So now I just like to ask this question, pass these questions to all of experts here. So what happened with the design? So if you want us to use the telemedicine, for example, like Prof. Juliana said, or other digital health applications, then what sort of language do you use? How do you translate our needs for example, to name a particular symptoms. And do we really have that complex linguistic expressions that represent this, Chris?
Yeah, I think, well, Chris may know a bit more than and others are the experts, but I think, machine learning has certainly allowed us to kind of use that language, natural language processing to actually apply to these different types of software and technologies. I think AI is certainly another way to use it in terms of a good kind of way to use AI from a positive way. Obviously, there's still lots of issues around that, and particularly around marginalised groups, as you say. So, look, I know Juliana's just put her hand up. She's more of an expert at this stuff too. So, I guess from my perspective, there are ways, I think, and obviously sometimes it's good old-fashioned butcher's paper and markers and visualising it, right? Sitting down and getting people to share their input. I'll let Juliana respond as well.
Thank you, Chris. So, like Chris mentioned before, NLP is potential applications in this area. But also, I would like to also highlight that Indonesia has so many dialects, like and some people, they only talk in their dialects. But at the same time, there are also doctors, physicians who are from these communities. So it is very important for the patients to know who they are. So basically, if they use telemedicine, for example, they can ask for consultation from people who, because of born in the community or because of marriage, actually can speak the dialect. So that's a way to bridge it beyond the NLP possibility.
Thank you, Juliana. Thank you, Chris. Thank you, Dea. Jade and Joanne, I've got it's sort of a statement and a question. You said something really important, Jade, and highlighted something that's obvious when you think about it, that in the setting of out-of-home care, that the key advocate for a child or a younger person, being the parent, is out of the loop. This sort of resonated with me. I'm relatively well off, live a comfortable life. My mother recently got quite sick and needed to urgently go to hospital, and the importance of me as her advocate got slapped in my face very quickly at one point, sort of crept up on me. I think of what might have happened if I wasn't there to witness this. So that's really important, for these people, these children who are not in a great state. Just a comment, firstly. Secondly, with this Sissy app, have you looked at, sorry, I'll just set the scene for the audience. We have a platform in Australia called the My Health Record System, which everyone can access if they wish. Every single citizen, 90% of our citizens have chosen to. It seeks to be a summary care record for people from a healthcare perspective. Have you looked at intersections with it, which could be good or bad? I'm not saying it's a wonderful solution, but interested in your comments, Joanne and Jade.
Yes, yeah. No, definitely. It's like, because I think what we've come to realise is that it actually, we want to be able to leverage off that kind of infrastructure if for people with care experiences, a dimension of that system has the functionality that they need, then that's going to be a much better outcome than sort of building an app in a system in a space that's not going to have that embeddedness in the infrastructure of the service going forward. So it's very much to sort of say that actually as that infrastructure develops, as it gets more trusted as well too, I think one of the issues that we'd have to think really carefully about is that and Jade probably have more to say about this as well too, it's the fact that to have to be in the government space, and so how do you do things so that it is, instead of being the government space, again, you being the subject of the government, that it is your trusted space and that it's seen as your way of, again, interfacing with government on equitable terms. So I'll let Jade jump in.
Well, I think in terms of the kinds of records that you can consolidate in that way, at least from the perspective of care experienced parents, can be quite dangerous for all of those records to accumulate, because the risk factors sort of defined and investigated by child protection are typically seeking assistance for a range of problems. So there's some very problematic ways in the ways that data are organised in those systems, and there's a lot of systemic bias and systematic racism through that. And Queensland dismissed its structured decision-making tool based on systematic racism. However, the decision-making process that fed into and taught the system is biased in exactly the same way. So it does what it does slower than the automated system. So we really need to kind of get better at understanding the implications of the way that we organise data and the way that it's used and the way that risk is assessed.
And I'll jump in again there and say, because, and this is where that participation in the record keeping is really important, to sort of understand, when are my records being accessed? What records are being accessed? Are they the records that have the incorrect information? One of the big issues in the sector is the amount of wrongness in the records. And so that ability to sort of have that level of transparency and oversight by the person within, there's all sorts of complexities there. It's like, but it is about, again, I guess a different way of thinking that is an equitable way of thinking, and saying, no, you're not just the subject, and we're not just going to use your records and information. You're going to know when that's happening and be able to have input and into that, so you're not blindsided by then things happening. Yeah.
Thank you both. Thank you. Chris, you have a comment?
Yeah, I was just going to add, in terms of the Indigenous number of Indigenous kids in out-of-home care in Australia is just outrageous. And this has been going on. I was a kid in out-of-home care when I was growing up. I was the ward of the state. So, as a foster kid, I know also that the detrimental impact it can have on you longevity of your life. Like, I mean, I'm not young. I might look young, but I'm not young. and so you didn't have to agree with me then, Chris. But yes, so I think that, this is really, I was really impressed, Jade and Joanne, with your work. So I'm going to follow you up on this stuff, because I think that, the kind of information that is there, the vulnerability of these young children and families who are caught up in the, just for the mere fact that they happen to be Indigenous when they check into the hospitals. And obviously, and sometimes it's obviously too, because it's young girls having babies, right? So they become instantly part of the whole system, the welfare system. And that's often where Indigenous kids are often, where DCP or child protection will come in, and they end in this cycle that goes around. So there does need to be really important data collection information and understanding how to access that information at some point in their lives. But, how do you track this and monitor it and evaluate those the kind of systems in place? But thank you.
Thanks, Chris. There are some commonalities with the more health medical worldview here, but interesting themes arise increasingly in the health sector, which I'm sure some of you will recognise from your own sectors as well. One of the great things about having more digital records is whilst there's the risk of more exposure, there is the chance of better communication. There's also the chance of better correction where things are wrong, if more people under appropriate controls get to see it. But then there's also a greater, and correctly so, expectation that the subject of that data knows what the hell's going on with it, knows when it's being looked at, when it's being shared, where it's being shared, why it's being shared, and has a sense of control, and also increasingly has the right to be forgotten. So the environment gets more and more complex. I guess it just reiterates that on top of all the wonderful technical things we can do in these health and social care spaces, this kind of viewpoint is very important to keep at the table and involved. Daya, I wanted to pick up So I'll come back to Chris, if that's all right. Just 1 second.
Yep.
Daya, you mentioned something really important in your work about collation, obviously, of information about people with a disability in your setting with contact tracing apps. But have you come across examples where that data has been used in a way detrimental to people with disability, either in your research or just from your reading of the literature?
No, actually not. This is a very unique to, I think we need to explore this further, Chris, because I think we do have lack of readings and evidence of users with disability from the global south. So what I presented with this collective, for example, so the collective feelings of using contact tracing app for the purpose of satisfying governments' programs or to support governments is very unique to these two countries, so Vietnam and Indonesia. But this is something that I think, as I mentioned in the last in my closing statement, is something that we need to further explore, because then the danger is actually there. So if they don't really have enough literacy and awareness about how contact tracing app works, and their voice are not included in the design, so the co-design process does not really include this particular community, then what they do is basically let the cultural values drive the decisions to use without knowing anything or how the impact of the CTA and how they can tackle such issues as community and individual.
Makes sense. Thank you, Dan. Chris, sorry, I didn't mean to cut you off. You had another comment, Chris Lawrence.
Yeah, I was just going to say too, I guess coming back, I think all of this, right? If you want to, use technology to make a difference for everyone really, and also for particularly marginalised, disadvantaged communities, it really comes back down to trust. And I think we don't look at, we haven't done really enough research around what does trust mean for these communities, right? We're trying to get them to use our software and do all this stuff, but I don't think we've got enough evidence to understand, well, what does trust really mean for these communities when it comes to technology and being involved in research projects like ours.
It's interesting too. There's something, and I'm talking about it. I've got a project in mind that we're on that's got lots of potential benefits for the broad community, but nowhere near as contentious as dealing with really tricky user groups. But even a tendency, even when one says at the start to all the funders of the project, we are going to be driven by what the users want, seeing that circumvented or blocked or whatever halfway through the project, even in a much more straightforward example, is a little concerning when one comes back to this kind of context where you really, really, really want to listen to what the users want, not cut it off halfway because you don't like what they're saying, right? So it's a real...
Can I jump in, Chris?
Sorry, I missed that.
Yeah, can I jump in? Just very
quickly. Please.
I think Chris Lawrence mentioned something very interesting. So just try to connect that with my presentation. So when Chris mentioned about trust, it's the trust to technology, or like, for example, in the case of using metaverse or virtual reality, it's a trust to the environment that we are safe. But with the Indonesian and Vietnam case, this is not about the trust of technology, because they obviously know nothing. They are very familiar with the lack of ability this technology to cater their unmet needs, but they actually do not have like enough trust to the technology, and therefore they're mentioned, I trust the state, I trust the country, I trust the government. It's not really the technology. So I think it's further widen the digital divides that have already been quite prominent and quite obvious for these particular users. Chris, thank you so much.
Yeah, I guess from an Indigenous perspective, here the trust, there's been a lot of mistrust because of the way Aboriginal Indigenous people have been treated historically, and so trust is a huge thing for us to be able to really incorporate some of those systems that are being developed. We saw that with the government, with the rollout of the government app around COVID, right? It was already ready made. They didn't even consult with anyone, not even non-Indigenous experts, and it was a failure. And so, you know, if that can tell you anything, it's not just about the political side of things. It's really, and they also used in WA, in Western Australia, they used that government app to actually track criminals and arrest them. And then that's when the trust was really kind of put on the table, right? No one wanted to check in. No one wanted to use it. That's what happens. It's about trust. More than just about politics. It's all those things.
Multiple dimensions of trust. Look, I think we're coming up to our closing time. I'm not seeing any questions come through from our attendees. So what I'm going to do is officially draw things to a close. Before I forget, I really want to thank our wonderful marketing and events team and the Faculty of IT who help us run these sessions. So thank you, Heather. Thank you, Kashan. Thank you, Eleanor. Thank you to Victoria, also is not on the line today. And I'd especially like to thank our wonderful speakers today. We've had a really rich conversation. So thank you, Joanne. Thank you, Dia. Thank you, Juliana. Thank you, Jade. And thank you, Chris Lawrence. For our audience, this session is recorded and then edited and is available on the FIT events site if people are interested to follow up later. And also once it's there, you're free to share those links with whomever you wish. So again, thank you very much to everybody involved. Really appreciated your time today and your insights. And I feel like I've been well connected the whole time down the special pipe from India. Nobody said, Chris, we can't hear you, so that's good. So thank you very much again, everybody. Have a great evening, and I'll go and have lunch in India. See you. Bye-bye.